these are again showing you the QRS complexes with the different leads. So the AVL, AVR, lead 2, AVF, this is the normal direction of the QRS vector in these patients, in normal patients. So you can see normal patient, lead 1 is positive, 2 is positive, 3 can be biphasic. AVR is always negative because the AVR is on the right shoulder and most of the QRS complex is going away from AVR. It is usually going towards AVL, so the AVL is also positive, but it is not as positive as lead 1 and 2. And then AVF is also positive. Now, very important thing before you start using the ECG to make any kind of diagnosis is to make sure that the person doing the ECG has put the electrodes in the right place. So usually it shouldn't be a problem because your machine will always give you, which electrode has to be attached to which part. So you will be attaching it to the right arm, right leg, left leg, and then you have a set of precordial leads that go from V1 to V6. But sometimes people make mistakes, and so they can switch different combinations. They can switch right arm to left arm, right arm to right leg, left arm to left leg. All sorts of different combinations are possible. So you should have some clues from the ECG that there has been some switch of the electrodes. And that's important because if you don't pay attention to that, you'll be making a wrong diagnosis when the real diagnosis is just switching of the leads. So there are different ways to do this, but if I start talking about lead switch, I can give you a whole talk on lead switch. So in the interest of giving a more comprehensive talk, I've just summarized different patterns that you can notice on ECG because of switching of the electrodes. The most common switch that we see is the right arm, left arm switch. So if you switch right arm and left arm, AVR and AVL are going to switch. So what happens is, when I showed you a normal one, I showed you that AVL is positive and AVR is negative. So in these patients, because you switch them, AVR becomes positive. So if you read any ECG and the first thing you notice is that the AVR is positive, either the patient has significant disease in the heart or they have switched the electrodes. And so then you look at lead 1 will also be switched because lead 1 is a lead that goes from the left arm to the right arm. If you switch the orientation, lead 1 is going to reverse in direction. So if the lead 1 becomes negative, AVR becomes positive, AVL becomes negative, instead of making a diagnosis of some abnormality, you should highly suspect that there's been reversal of right arm, left arm leads. Similarly, you can have left leg, right arm lead reversal. Here, AVF and AVR will switch places. So the clues to these would be looking at an old ECG of the patient. And if things have changed in these particular leads, then you think about these switches. If you have a left arm, left lead switch, you again would have to look at the vector configuration of the AVL and AVF and how they look like earlier and how do they look like now. If you reverse, the right leg lead is the grounding lead. Okay, so if they switch right leg lead to right arm or left arm, that is very easy to diagnose because one of the leads then becomes flat. Okay, and so that is very easy. If you switch right arm with the right leg with left arm, then lead 3, which was supposed to be a lead between left leg, left arm and left leg, is now going between right leg and left leg, and so there is no vector there, so it becomes flat. Similarly, if you see no voltage in lead 2, you should suspect right leg, right arm reversal. Okay, so if right leg is reversed with any of these things, it's very easy to diagnose. You just get a flat signal in lead 3 or lead 2. Now, if you look at precordial leads, they are placed in the V1 is placed on the right side of the chest. Then you start V2, V3, V4, V5, and V6 on the left side. And you start from the intercostal spaces and you go down. So this is the normal pattern of activation of V1 to V6 in a patient who has a normal heart. So V1 looks more like small r with the big QRS, and the R wave slowly grows as you go from V1 to V6. Because as you start going more towards the left ventricle, which is where most of the voltage is. If you were to switch, if you see that the pattern changes, then you should think of reversal. For example, if you look in the patient below, V1, V2, R wave is slowly growing. Suddenly it becomes very big in V5, and then again it becomes small in V4, and then V5 that is marked is even worse, more smaller, then it's big. Then you know that what kind of switch has happened. So this is relatively easier to pick up. You will just see that the pattern, which is supposed to be following one particular pattern, has changed. Now, sometimes patients have right ventricular hypertrophy where they will have bigger voltages here, but still the transition should be occurring smoothly rather than abrupt change in one lead. Anytime you see an abrupt change in one lead and then it reverses in the other leads, you know there has been a switch in the precordial leads. Now, one important distinction that you have to make is between whether the patient has a right arm, left arm switch or the patient has dextrocardia. So dextrocardia means the heart is located on the right side of the chest instead of the left side of the chest. So if that happens, in that also, there will be a atypical pattern in AVR and lead 1. So I told you that if AVR becomes positive and lead 1 becomes negative, you should think of lead switch. So how do you know whether it's a lead switch versus dextrocardia? Because both of them will give you the same pattern in AVR and lead 1. And the important thing is looking at the precordial leads. Because now, in this normal heart position, if you look at the precordial leads, which were V1, V2, V3, V4, V5, V6, the R waves were slowly growing as you were going across. Whereas if the heart has then moved over here, what will happen is, as you go from now V1, V2, V3, V4, V5, V6 are here, but the heart is lying over here. So most of the voltage is going to be in V1 and V2. And as you keep going down, the voltage will be going in the other direction. So if you see a reversal of voltage pattern in V1 to V6, along with that atypical pattern in AVR and lead 1, you should think of dextrocardia. Whereas if you see a normal voltage pattern in V1 to V6, but AVR and lead 1 are reversed, then you know it's a lead switch. So this is an example that's showing you where lead 1 and AVR have reversed, and the precordial pattern is still the same as you would expect. And so then this would not be dextrocardia. This would be a lead switch.